You're good. Morning. No, okay. Would somebody mind saying something just to make sure my speakers are working out? I'm not sure. Okay. I'm good.
All right, everyone, it is that time again. So Bill's already had a sound check, which is good because he's our presenter for today. I'm Joyce Troxler. I'm your facilitator here for I Am Echo. This is our 5th series of doing this, which is hard to believe. We've done this 5 times now, started, stopped, and started again, but this is big number 5. One big difference this time is we've changed our name from BMAT Echo to I Am Echo. So I hope everyone from before found it easy to find us again. So thank you for joining us. And if you've got some friends that you think would enjoy joining us as well, let them know where we are and who we are. The I Am of I Am Echo stands for Interdisciplinary Addiction Medicine. It's one of those things that we recognize with the work that we were doing through this echo. It was a lot more than just buprenorphine medication assisted treatment, which I think is one of the great things about this format is we do get to share a lot more because we do want to provide comprehensive care for individuals with substance use disorder. And this is a way for us to share knowledge and learn from one another. So again, thank you for joining us. I am going to attempt to make, I'm on a different computer in a different room. So things are a little wonky. I need to change my view so I can see all your wonderful faces. So we can go around and do interviews. That's happening later today for us because the Addiction Medicine Fellowship is conducting interviews for next year's fellows already. So interviews are on my mind, but I want introductions from everybody. So if you don't mind just going around as I call your name and stating your background a little bit, kind of what area that you work in that addresses substance use disorder. And it could just simply be, I am curious, I'm not doing anything currently, I saw your echo and I want a company over lunch. And that's why you're here. Whatever it is, we want to hear and know more about you. Meredith, if you don't mind unmuting and introducing, please.
Hi, my name is Meredith Ginley. I'm an assistant professor in the Department of Psychology at ETSU, and I'm a licensed clinical psychologist, and I'm a member of the HUB team.
Fabulous. Thank you, Meredith. Bill, if you can go ahead and unmute and introduce.
Oh my gosh, look at this group today. Really good to see everyone. I'm Bill Brooks, assistant professor of biostatistics in the College of Public Health. I would say that I am very curious and I love to talk about substance use whenever I'm allowed to. I do work closely with the Addiction Science Center and other folks around campus working in and around addiction.
Fabulous. Thank you, Bill. David Roan, if you could unmute and introduce, please.
Yeah, I'm David Roan. I'm a professor in pharmaceutical sciences in the College of Pharmacy, and in a previous life was a substance abuse counselor at Iowa Methodist Medical Center.
Fabulous. It's good to have you again joining us, David. Thank you for being here. Michael, if you can unmute and introduce, please.
I'm Michael Mishka. I'm a psychologist and a clinical director for behavioral health operations at Division of 10 Care in Nashville.
Fabulous. It's also wonderful having you joining us again, Michael. Thank you for being here.
Thank you.
Melissa, who has I Am Echo as her name. If you can unmute and introduce for us.
Hi, I'm Melissa Hood. I'm the educational planner for this program and also as of right now, your tech person. If you need any help with tech, please send me a message in the chat box. And also, I just want to take a moment to remind you to complete the evaluations. And we are working on getting a few more credits, but we do have nursing and social work credit approved as of now. So that's a little bit of a good thing along with our new program here. So thank you all for joining us today.
Perfect. Thank you, Melissa. That is actually a really important point. Previously, we just were approved for continuing medical education credits for those of us who are physician types, but we're expanding. So definitely check in and see if you are represented as someone that we've been able to get continuing education credits for, because you may be able to cash in, not just, I spend time with this really cool crew of people and I enjoy it, but you can get some continuing education credits as well. Aaron, if you can unmute and introduce.
Hello, everyone. It's good to see everybody. So I'm Aaron Solon. I completed a research fellowship at ETSU a couple years ago, studying substance use disorders and pharmacist interventions. So it's good to see Dr. Roan and Bill and everybody. So right now, I'm a clinical pharmacist working at Nyack Hospital in New York, specializing in psychiatry. We have a 26-bed inpatient unit as well as a recovery center. So I'm working with patients with substance use disorders as well. We also have an outpatient rehab program that I'm working on, starting medication education groups as well. And also, I just wanted to let everyone know here, Dr. Sarah Mellon was asked to do a grand rounds for ETSU psychiatry next Friday, but she could not do it, so she deferred to me. So I will be presenting on postpartum depression and some research that I've done with women who have recovered from postpartum depression next Friday. So if you're interested in joining, it would be great.
That's fabulous, Anne, and congratulations on the new job. It's fantastic, and I'm so glad you joined us. If you don't mind emailing somebody associated with us here at ECHO that information on the grand rounds, and we'll send it out to everybody too. Because hey, we want to show up and support our guy, okay?
That'd be great. Thank you.
Awesome. Good deal. Andrea, if you can unmute and introduce, please.
I'm Andrea Hopkins. I am a physician faculty member at ETSU Family Medicine in Bristol, and just here to learn more.
Tickles me pink to see you there, Andrea. I'm glad you've joined us. Thank you so much. Katie Langley, if you can unmute and introduce, please.
My name is Katie Langley, and I am in the psychiatric nurse practitioner DNP program at ETSU.
Fabulous, Katie. It's nice to have you joining us. I realize you're in a place where we can't see your wonderful face, so stay safe. I was going to ask Rick to introduce, but he just stepped away. We'll get him when he comes back. Oh, here he comes. Hi, Rick.
Hi, everybody. I am Rick Wallace. I'm the Associate Director for Evidence and Outreach for the College of Medicine Library. I'm a professor in the College of Medicine and do searching for the group.
Fabulous. Thank you, Rick. You guys will notice your chat will start to light up the more we talk because Rick's going to be pulling articles for us and putting them up. So you guys will have links to articles that have more information about the topics we're discussing. Thank you, Rick. Judy, if you can unmute and introduce, please.
Hi, Joyce. I saw you last at the Women of Mountain City when we did a health fair in the community. Judy McCook, Professor, College of Nursing. I have been a maternal infant clinical nurse specialist for almost 40 years. And in 2016, I got trained as a SANE nurse to do sexual assault nurse exams. And we have trained over 100 nurses in this region, Southwest Virginia, Northeast Tennessee, to do SANE exams. So part of a grant on that. So, and part of the Strong Brain Institute with David.
That's fabulous. I'm glad you're here with us, Judy. It's nice to see you again. Addiction Medicine Fellowship Room, if you guys can unmute and just go around and say who you all are.
There you go.
I'm Dr. Justin Owens. I'm one of the new fellows here.
And I'm Veronica Van Ray. I'm a social worker and certified peer recovery specialist.
I'm Tanya Milam. I'm the medical assistant with the fellowship program.
I'm Caleb Osborne. I'm one of the fellows here. And
Cameron Hyo. I'm sitting here.
Awesome. Thank you, guys. This is our addiction medicine team. So we've got a well-rounded crew there. Cameron, didn't say this, but he is one of the addictionologists that we have as faculty for the fellowship, and he's a psychiatrist. Thank you guys for being here with us. They're also kind of required, but thanks for being here. Rebecca, if you want to unmute and introduce, please.
Hi, I'm echoing. Are you muted? Thank you. You still can't hear me. Can you?
I can't hear you, but it's okay. They can.
Yeah.
They can.
Yeah.
I am Rebecca Mahar. I am the new ECHO coordinator, and I am also the fellowship coordinator for the addiction medicine program here.
Wonderful. Thank you, Rebecca. Rebecca is the one you're going to refer a lot of questions to as far as, you know, like if you have a case that you present and you just really don't know how to get that done. She's the one who can help guide you through that. Or if you have any other questions, just direct them to Rebecca. She'll either answer them or get them to the place that they need to go to get answered. Awesome. Thank you for being with us, Rebecca. Rachel, if you can unmute and introduce, please.
Hello, everyone. Thank you for having me. I am a clinical psychology doctoral candidate at ETSU. I'm currently working up in Mountain City Extended Hours Clinic, providing therapeutic services up here. But previously, I was working directly with offenders on probation, in which I would say my primary therapeutic response was substance use intervention. So I'm really happy to be here.
We're really happy to have you with us, Rachel. Thank you for joining. It's good to see you. Chris Copeland, if you can unmute and introduce, please.
Yeah, I'm Chris. I'm a addictionologist with Revita Recovery at the Newport office.
Beautiful. It's good to see you again, Chris. Chris is a long time joining ECHO.
Got my camera working. I'm very proud.
I'm very proud too. It's nice to see you. Carrie Lynn, if you can unmute and introduce, please.
Hi, everyone. I'm Carrie Lynn Dowling-McClay, and I'm an assistant professor at the ETSU Gatton College of Pharmacy. One of the projects I'm working on right now is with Bill Brooks. We are working on a secondary data analysis looking at buprenorphine prescribing for opioid use disorder during pregnancy and postpartum. And so having a lot of fun with that and excited to be here and listen.
Fabulous. It's good to have you with us again, Carolyn. Diana, if you can unmute and introduce, please.
Hello, I'm Diana Pure, and I'm a general pediatrician with ETSU Health Pediatrics, and also the medical director for our Baby Steps Clinic, which is an interdisciplinary clinic following our kiddos 0 to 5 years who have been prenatally substance exposed. So I'm excited to join this group today.
We're excited to have you with us. Lovely. Thank you, Diana. Brandy Dahl, if you can unmute and introduce, please.
Hello, I'm Brandy Dahl. I am also at the Gatton College of Pharmacy with Carrie Lynn and David Roan, and I practice at the Bristol ETSU Family Medicine Clinic. I'm actually right next door to Dr. Hopkins, so just here to learn more.
Fabulous. It's good to have you with us, Brandy. Bristol is representing well. We're going to have to get Kingsport to step it up, I think. April Morrison, if you can unmute and introduce, please. We'll give April a moment to find her unmute button and give us an introduction, but I'll go ahead and ask Carmen Jones if she can unmute and introduce.
Hi, I'm Carmen Jones. I'm a nurse practitioner, psychiatric mental health with the ETSU clinics. I'm the residency program with ETSU. And so I'm finishing up my doctorate while I'm doing the residency. It's a year. I'm really excited to hear about all these things going on with perinatal mental health.
Beautiful. Well, we're very happy to have you joining us, Carmen. Thank you for being here.
Thank you.
Excellent. All right. Ooh. Christy has just joined us, it looks like. Christy, if you want to unmute and introduce.
Hi, my name is Christy. I am a family nurse practitioner with the residency program through ETS at Mountain City Extended Hours Clinic.
Wonderful. It's good to have you with us, Christy. Thank you so much for joining.
Thank you.
Excellent. All right. If anybody else new joins us in a normal kind of break section, I'll just get them to unmute and introduce. But right now we need to turn it over to Bill Brooks so he can give us his talk on harm reduction. Thank you, Bill.
All right. Thank you, Joyce. And welcome to everyone. There's some friendly faces in the crowd. It's really good to see you, Aaron. Congrats on the new job. Let's see, let me get everything going here. Takes me just a second. Swap, because I like it to be right where I'm at. Oh, hang on. I think I'm good. I need to share it actually. Swap it back. Apologies. Every time I think I'm good at this. Let's do screen. One, share, and swap. Okay, are you guys seeing my title slide?
Looks good.
Fantastic. All right. Move this out of my way. Okay. Start my timer so I can stick with it. I love giving this talk. I've done it, I guess would be my 5th time if this is session or iteration 5. I had to go back through my slides to take out some of the instances of opioid just as a focus for the presentation, because we are expanding in kind of response to the changing dynamic of the overdose crisis and just substance use trends and changes in the illicit drug market nationally. One of the reasons that I'm excited to do this lecture today is because I get to go through some of the updated data that I know that we've all been talking about, but was able to pull from NIH this week, and it's pretty illuminating as well as concerning. So I do not have any disclosures at this time. Our objectives today, we're going to talk briefly about the trends in drug overdose, a little bit more than I have in the past, just because things have changed somewhat in the last few years. I want to make sure that we highlight that. Go just sort of a reminder of the risk factors, talk specifically about harm reduction and sort of its role in preventing overdose, and then incorporating harm reduction into primary care or addiction medicine practice. The reason that we start with harm reduction in these echoes is because it's kind of an underlying thread for our kind of approach to addiction, treatment and recovery, prevention, and all of it is sort of with a lens towards harm reduction. So I'm going to try to make that as clear as possible for everyone, though I think most of us are pretty familiar. So looking at the overdose trends, I don't have 2020 on this particular figure here. I'll have it in a later one just to highlight where we're at, but we did see a bit of a plateau and even a decline in 2018, which was very encouraging. As you'll see, that hasn't really held in the most recent data. Of course, a huge factor involved in that is the pandemic that we've all been going through and its impact on access to services. So looking at just the overall national drug trends, the overdose deaths in 2019, I want you to hone in on 3 particular trend lines. Of course, the orange one that is well above all the rest, that's our synthetic opioids, specifically fentanyl and its analogs, responsible for a ton of overdoses and overdose deaths in the US. It is the single most deadly substance in the illicit drug market today. But otherwise, sort of buried down there with the rest, is we're seeing the light blue psychostimulants, specifically methamphetamines, and then cocaine on the rise as being responsible or involved in overdose deaths, moving from 2015 specifically into 2019. Any deaths involving any opioid, we're still seeing that upward trend. So despite the fact that we're seeing some diversity in the substances being prevalent in our death certificate, our toxicology reports and so forth, opioids are still playing a huge role in our mortality, as all of you I'm sure know. Again, specifically fentanyl and its adulteration or substitution for different substances that it can mimic visually. We have seen that decline in deaths involving prescription opioids. Of course, this varies by region, but overall, nationally, we have seen that decline. And this is predominantly due to our prevention efforts, cracking down on diversion, prescription drug monitoring programs, and other sort of education around this. I think that the media has really gotten the word out about the dangers of prescription opioids. And so the huge sort of spike we were seeing in the 90s and then into the early aughts has kind of plateaued and begun to decline with regard to the prescription analgesics. However, heroin, of course, really got into its own, around starting in 2011, it started to increase there. And this was, theorized that as we crack down on access to prescription opioids, that population that was actively addicted had to go and seek their medication in the illicit drug market. And so, of course, heroin was readily available. It's very potent, it's very cheap. And we're seeing, if you look at the specific sort of yellow and green lines there, heroin combination with fentanyl, that sort of population of folks that are overdosing due to accidental or intentional exposure to fentanyl have, constituting a huge portion of our overdoses. And you can see that, that decline in just straight heroin responsible for overdoses, again, sort of highlighting the role that fentanyl is playing in our overdose crisis. Looking then at psychostimulants, primarily methamphetamine, we see this steady increase here. And what's interesting and what we'll highlight when we compare cocaine to methamphetamine is that the psychostimulants, the methamphetamine specifically, that are in combination with fentanyl are actually lower here, highlighted here, than the trend line we're seeing for those without any opioid. And that is a product of the significant change in quality and potency of methamphetamine in the US as it was began to be produced predominantly south of the border by the cartels, and is more of a crystalline form, though we do have quite a bit of homegrown methamphetamine in our region. Cocaine is an opposite trend. We see that the cocaine involved with the synthetic opioids quite a bit higher than those without. That is, a product again of, sort of the steady quality of cocaine during this time period. And again, the adulteration of cocaine supply in the illicit market with fentanyl. So yes, in 2020, May 2020 to May 2021, we logged the highest number of overdoses in our history. Very discouraging and very telling of sort of the impacts of our infrastructure, our treatment services and so forth on affecting the overdose curves. This is quickly just showing kind of past year use. We're seeing, if we look at the top line there, those circles, that's past month use of heroin use among folks who report past month methamphetamine use. So again, just kind of highlighting the role of opioids within that population of folks using methamphetamine. However, if we look at it closer, specifically between cocaine and methamphetamine, the figure on the left is with synthetic opioids, fentanyl. The figure on the right is without synthetic opioids. If you look at it, it looks like the synthetic opioids are much more responsible in overdose among, or deaths among folks with cocaine involvement than with stimulants. However, when you look at those overdoses among folks who don't have a concomitant synthetic opioid in their toxicology, then you see that the stimulants are themselves, the methamphetamine is responsible for overdose deaths. Okay, so I've gotten through that. And that took up a lot of time. So misuse and use disorder risk factors, I think that just judging by the folks that are on the call today, I think we could all sort of create a list that's much more comprehensive than this. But, just in general, from a harm reduction standpoint, recognizing the kind of life course impacts on motivation and behavior towards misuse and use disorder in our populations. So what is harm reduction? It's essentially a set of policies and programs, practices aimed at reducing the negative consequences associated with drug use or other risk behavior. I added the other risky behavior here because I want to make sure, in my mind, harm reduction is sort of ubiquitous as we work towards acceptance of ourselves and the behavior that we are inclined towards, and how that kind of relates to folks that we serve and work with otherwise that may be engaging in behaviors that might be destructive, or harmful. Harm reduction strategies include reducing stigma first and foremost, right? So we change our own perspective and then we start spreading that message around. That's really sort of job one: increasing access to evidence-based treatment, increasing access to naloxone with regard to opioid overdose, teaching safer injection practices and safer use, provide access to needle exchange, and consider implementing sites for safer injection. So really, if you can see the through thread here, starting with reducing stigma as an acceptance of this population's need for services, and without a stipulation toward changing their behavior or quitting the behavior, or specifically moving into treatment necessarily, but that we do what we can to reduce the harms of that particular behavior. So where does harm reduction land sort of in the continuum of prevention? It's not often considered part of prevention, but I am going to make that case. Here, in public health, we talk about primary, secondary, and tertiary prevention. In primary prevention, we're trying to prevent any sort of beginning of misuse. So any sort of experimentation with regard to substance use, this typically occurs in our adolescent population. With our secondary prevention, we're working towards screening, and we're trying to prevent movement from experimentation or misuse into a use disorder. And then, of course, when we're focused on tertiary prevention, where harm reduction sort of lives, we're mitigating the impacts of the behavior so that it doesn't lead to more severe outcomes. And incorporating that into clinical practice can include things like screening for OUD or for other substance use disorders, talking with patients about treatment and coordinating with providers, providing counseling service, prescribing buprenorphine, as well as co-prescribing naloxone. I think, I'm going to mention this later, but coordinating with other providers and other folks in your region that can provide services that you're not able to or aren't interested in providing, I think is probably one of the most important things we can do to assist our treatment populations or our patient populations wherever we're seeing them. So there are certainly some evidence-based programs towards treatment, medically assisted treatment, or medication for opioid use disorder. The sort of vote is in a lot of ways, as far as I'm concerned, about the effectiveness of this treatment. So replacing opioids with medication that can be managed is incredibly effective in keeping folks in treatment. Considering that we are now looking at stimulants and their role in our current trends, it bears mentioning contingency management is really sort of where we're at right now. I know that some folks are going to talk later in the ECHO about some possible innovative pharmacological therapies, but contingency management is something that we're looking at here at ETSU. It has a good evidence base. Dr. Ginley is the current expert on our team, and I think potentially outside of ETSU as well, on contingency management. And so it does have a good evidence base, like I said, about increasing number of weeks in treatment and duration of abstinence. I won't really go into it other than to say that it's based on negative urine drug screens, and there's a reward system, a sort of incentive towards curbing use of other substances like stimulants if you're in, say, opioid use disorder treatment. Naloxone, as we all know, this is, again, 7 years ago, we would have to convince folks, but I think, it's clear now naloxone is very effective in preventing mortality from overdose, and it's something that we should all have on our plate as sort of tools that we use towards harm reduction. Syringe programs, I could honestly sit here and talk about syringe programs all day long. I don't think we currently know all of the benefits of syringe programs because of politics and sort of cultural barriers, we're not yet able to fully realize a syringe program. So there are quite a lot of them around the country, but we really can do a lot to not only prevent, infections, HIV, HCV in these populations, but we can also do a lot to get folks in treatment and prevent overdose. So key tenets: we minimize harm versus ignoring or condemning, right? We're focused on functioning and well-being rather than cessation. We acknowledge the continuum of behavior, right? Substance use is not substance use is not substance use. Everybody is sort of on their path as far as that is concerned, and we need to be centered on the patient when we're talking about these things. recognizes the cumulative effect of social determinants, right? Where you live matters, what your life course has brought, and sort of the interaction of all of those things dictating or predicting your behavior. We're neutral on legalization of decriminalization. We just don't get into that debate. Though I think a lot of people do, and we all have opinions. Maximize is what we do in harm reduction, really gives us the opportunity to maximize intervention options. So thinking in terms of stages of change, this is this wheel that we all go through and all the things that we try to do to be healthier and make positive shifts in our life. And we contemplate, then we get ready to do it, we do it, then we have to maintain it, then we relapse, and we're pre-contemplation, and so forth and so on. With harm reduction, we're able to interact with folks at pre-contemplation, which means that there's no stipulation that they have begun to seek information about behavior change or in any way sought assistance towards behavior change. We get to have a positive and supportive interaction with those folks at that stage, which is impossible otherwise, unless we're a part of that population. Just kind of laying out some of the things that are important in our strategies towards preventing overdose. So ensuring access to treatment, providing or knowing where to refer treatment. So just the options for medication-assisted treatment and other forms of treatment. Information about this stuff can be accessed. SAMHSA has a really great resource for these types of things. And I think actually some of the folks at ETSU are building databases around this as well. So what you can do in the office setting. So first and foremost, let's just be patient-centered. That's, it's catchphrase, and we're all sort of on board with that. Just make sure that we keep that in the back of our minds. I'm not a clinician, so I won't preach to you about how to manage your practice. I'll just talk to you about sort of how, harm reduction is a perspective that we can carry through, and it has a positive impact, I think, on the whole community, frankly. Integrating primary care and behavioral health care is, an important approach. Considering offering medication-assisted treatment, addiction counseling, flexible treatment goals. So having sort of, educating yourself on the cycle of relapse and, having realistic goals as far as, working with those patients. And then establishing collaborative relationships. Again, I think this is really, really important and can have a huge impact. And then providing recovery-oriented support services. We're doing a lot of work at ETSU around peer-supported recovery, and hopefully there'll be some gains made in that area soon. Okay, so takeaways. I'll just blaze through all of this. Harm reduction is a set of policies meant to reduce the harms associated with drug use as well as other risky behavior. If we're able to talk about addiction simply and its risks, screening, and facilitating treatment, then we can really help prevent adverse outcomes for our patients. Replacement therapy like buprenorphine, methadone, and co-prescribing naloxone can go a long way to protecting our patients. And then bottom line is through respectful and appropriate engagement with people who use drugs, we can create opportunity for intervention where there otherwise would be none. And that is my message today. Thanks for listening.
Fantastic. Thank you, Bill. Anybody with questions for Bill regarding his presentation today? It's an important message, and it's one that I think being reminded of is always good to hear. David, what have you got, sir?
Yeah, and I apologize if these are not questions right at the data that you presented, but it's about other data. I just wondered, when I was looking at population statistics, if there are any corollary statistics on the number of changes in the number of people that are addicted, may not be, and or the number of people that are in any kind of therapy. So is the patient population changing?
I would open that up to other folks on the call. I can tell you that from a data standpoint, I think, David, as you know, we actually have better data at this point on use and less comprehensive data on use disorder. But I think maybe others who are more clinically focused might be able to provide some insight as well.
I'm not the greatest with acronyms, so I'm going to screw up the acronym, but it's where some of that, I think it's through SAMHSA. Which organization would you have those slides from with all of the data points? It's either NIDA or SAMHSA or one of those. They're the ones that put out the big set of data, and they look at the number of people with substance use disorder and who's using it.
NISDA.
Yes, maybe
Or-
that's the one. But when we look like the 2018 to 2019 data, it really didn't change. Like it was maybe 1 percentage point different between, you know, past use, you know, different age ranges, all that kind of stuff. It doesn't look like it shifted very much. Actually, I think what will be interesting with the number of overdose deaths that we've seen in 2020 is when we get the 2020 data set. Like, are those numbers going to increase? Like, are we having more people who are reporting use in the past year? Or are we having, what is that going to look like? Is it people who are using more, same number of people using, but they've used more, and so we have more overdose deaths, or it's a shift in supply? Because that's one of the big things that we're thinking is associated with overdose is the shift in supply, like where we're getting it from. As Bill alluded to, the potency of what we're getting, it's really not the, you know, I cook it up in the bathroom of my shack. I'm getting this from Mexico because it's much cheaper. And so it's a very different product than what people are used to as far as stimulants go. The fact that fentanyl is showing up in just about everything that's being used. So I think that's part of it too. So I think the 2020 data may show us something that gets to that question, David, but I know the 2018 to 2019 data really did not shift as far as people reporting use in the last year, the type of substances they were using. There wasn't a lot of change in that data.
Yeah, and thanks, Joyce. And the 2020 should be out, I believe, in October. My GA and I are watching closely for that to be released. You know, I was at the heroin and prescription opioid summit, and there was some folks from Border Control, and they reported that fentanyl seizures at the southern border were up 70% this last year, and that heroin was actually down marginally by about 8%. So, you know, it really does look like that in, you know, true cartel fashion, as they've done, you know, over and over in the past, they saw which way the wind was blowing and they made sure that the supply was there.
I'm going to go ahead and have us transition over to our case. We've got Caleb Osborne, one of our fellows, who's going to present a case today. So I know they may need to get their screen set up so they can share that, or just so that he can get prepared to get that case ready for us. I'm actually also going to transition away and turn it over to Cameron Hyel. We've got a scheduling overlap. There's I always get this wrong. Child Protective Services, Department of Children's Services, ECHO that's also going on now that I'm helping out with. So I'm going to step from this ECHO into another ECHO. And I'll do that again on September 15th, I believe, is when this group gets together. Is it September 15th or 8th that we're getting? I think it's September 8th.
Yeah.
Is our next one 8th. So we'll be getting back together, you guys, September 8th. I will see you then. I will not be stepping out of that one into another ECHO. That's just today that I need to do that. So even though it is our first one, I'm bailing on you early. So I apologize for doing that. But I am more than excited to have us up and running again with our new totally cool name of I Am ECHO. So I look forward to seeing you all on September 8th. I'm the only one who's allowed to leave. Everybody else stays and listens to Caleb's awesome case. Okay. All right. Thank you all, everyone. Thank you, Cameron, for covering for me.
There you go. All right. So I do have a case today. I don't have anything to share as far as like screen share, but our clinical question for the day is regarding handling dual relationships between patients. We do know that we try to avoid dual relationships at all costs. That's sort of not just within addiction medicine, that's sort of medicine across the board. You try to avoid them when you can, and at times they are unavoidable. But particularly within smaller communities, in dealing with addiction medicine, it's very frequent that you're going to have patients who know one another or are related to one another. And so this is regarding handling those, less so about dual relationship between clinician and patient. And so for our case today, we have a 35-year-old female and a 39-year-old male. They are both being treated for opioid use disorder. They have some polysubstance use history, but nothing that's been really significant going back through their kind of their timeline of substance use. For both of them, it's really been pretty consistent since teenage years. It's been opioids. He does not have any other medical history. She has a chronic kidney disease that was from vancomycin, and the vancomycin was for endocarditis that she had years ago. So in being treated for that, she got some kidney disease. Neither one of them have any significant psychiatric comorbidities. And other than her heart medications, blood pressure medications, neither one of them are being treated for other comorbid conditions. They have both been in some outpatient programs before, no IOP or inpatient, nothing residential. And part of their social history, his, we do all sort of their screenings for the PHQ-9, the GAD-7. We do the cross-cutting questionnaire as well. And they both scored relatively high on the GAD-7. And his ACE score was 1. She actually has not had that assessment done yet. We typically work on doing those in the first few visits, and they've had some trouble getting in consistently to the clinic. And so I'm still working on getting all of the assessments done for them. As far as I know, to the best of our knowledge, neither one of them have known incarcerations or ongoing legal issues. They do have some child support issues. She is receiving child support from a father of other children that she has, and then he is also paying child support to a different mother. And they've had some DCS involvement as well, but they currently have their children living with them. They have stable housing. Female patient is working on disability due to her cardiac history. The male patient is currently unemployed but looking for jobs, and their support system is really kind of just the two of them is about the only reported support that they have. As far as family history, he has no family history listed. He didn't have any significant substance use in his parents. Her parents used alcohol, but not a whole lot there either as far as family history. So for these patients, as far as their presentation to our clinic, they both had some, like I mentioned, some hiccups getting in consistently. They presented last year to start outpatient treatment, and he had already been coming for a little bit and was not able to be here consistently. And then she came for, I believe, 2 visits back in November of last year, and then hadn't seen either one of them for a while until they came back to reestablish about 6 weeks ago. And so both of them are on buprenorphine. He is on 12 milligrams a day. She is on 8. And in starting them. For him, he had had a stable dose relatively prior to not seeing us for a while, but she had not. And so her history as far as dose and use of buprenorphine was she was doing 2 milligrams some days, she was doing 4 milligrams other days, she was doing just kind of quarter strips here and there, and so didn't really have a stable dose. He more or less knew what his stable dose had been before. So we got them established first visit, and part of you know, their care and what has been one of the sort of issues that has been ongoing is they have children together who are still young, and so the children are with them at the visit, and a lot of times it's hard to separate them and put them in, have them in different rooms for treatment for their visits because they're wanting to be together, have the children with them. And so an ongoing concern is it's difficult, with that being the case, to get traction for either one of them to begin doing well individually if they're not both doing well. And so what has been a consistent issue is if there's you know, an insurance issue and the medication isn't able to be filled for a day or two, or if someone misses an appointment and is not able to get a fill, they're pretty consistently sharing medications. And so that has been hard to get either one of them on a stable dose, not knowing you know, what consistent dose they've been taking. And so that's really the big clinical question is what sort of strategies that you have. Some things that we've done so far, we have tried to have them see different providers and have them seen at the same time by different providers. But other than that, we are kind of having a little bit of a difficult time just because it is hard to get either one going individually. So that's the clinical question is when you have patients whose recoveries affect one another's recoveries, what are some strategies you can use to help gain some traction?
Okay, I just wanted, you know, give you a brief of that one. 35 years old, 39 years old, they are in a relationship, they are taking care of their kids. They both have a diagnosis of the OUD. They prescribed buprenorphine for both of them, but separating them when they come in because they do have 2 kids that they need to bring with them. They are young kids, almost babies, and they have to put them in the same room, or sometimes we can separate them from the different room. So that kind of interfere with the individual treatment when they share the medication if one of them is not able to make it to the appointment. And the most of the question that was made is, in this situation, what would be the best approach from your experience in the past? What can be done differently so we get them more individualized treatment for each patient? And this is open to everyone to give them the suggestion. Any suggestion, any?
I have a question, Cameron. What were they doing in that gap between treatment episodes? Were they in active use, return to use, or were they getting prescribed from a different clinic?
Yeah, they were still in active use, primarily opiates, and they pills primarily. And so that was one of the things sort of with the earlier visits as well is, you know, if one of them missed medication, then they would share. But if they got to the point where they were, you know, out of even the shared medication, then it was sort of right back to oxycodone primarily. And that was what they were doing in between, you know, in those months in between as well.
Any suggestion?
This is like a combo question suggestion. Have you, it sounds like there's been efforts made to like have them be separate and kind of engage in their own individual treatment plan. Have you had like, I don't know the expression, that come to Jesus meeting sort of like guys, you are making this really hard for each other, like kind of have them both in the same room and like just like lay it all out there, like how you're like the concerns you're having, and see if they can come up with solutions. But it sounds like there's just a lot of like unique specific circumstances that maybe they're the best people to help you kind of problem solve through. But I don't know, it sounds like I'm hearing maybe you've already had that attempt prior to them trying to separate them.
Yeah, we have actually had, I guess, at this point, 2 different visits where they've been separated. And on one of them, one of the patients no-showed the appointment and ended up sort of piggybacking on the other one. And then the most recent one was today, and they were not here for that. So we've attempted separating them before just from a scheduling standpoint. And then also we've attempted to separate them just not even by seeing different providers, but same provider, same day. And then when they get here, we say, okay, we'll have you in different rooms. And they say, no, we want to be in the same room. Well, yeah.
Okay, so I guess that's my thought is like, can you have them together? Like, can you like treat them as a like unit and make them work together?
It would be good if they would come together. And the problem is, you know, preparing 2 kids in the morning or getting here, it's been always their complaint that is hard. And then so we decided to give them the option of one of them comes for their treatment this week and the other one comes next week or some other day of the week. And they did not like that one because of that would be 2 trips for them to come. I think that that is a very difficult situation, because if you want to treat one, you won't be able to treat that person because they're going to share medication with the partner. So we have to treat them together. In the same time, bringing them together with these 2 small children that they always have a complaint about it, that they can't do that. So
that's been part of the.
I'm sorry, I had a thought. I mean, the thought that I have is not the most ideal in terms of the benefits of treatment, but have you considered switching the MOUD to like naltrexone or Vivitrol with this group? If you were to get them onto a 30-day injectable, I understand that Vivitrol does not necessarily have the mortality benefit that buprenorphine does, and that transition process is difficult. Meaning they have to be opioid free for 7 to 10 days, potentially longer if they're using buprenorphine. But I'm wondering if a shot a day is more feasible than these mixed visits or these lapses in care.
And yeah, so Aaron, to your point, that part of that issue is that substance-free period, and we've not been able to attain that at this point. And so that's part of the issue. And Judy, that is something that is on our minds as well. that was in the chat, some regarding some maybe controlling behaviors on his part. And that is part of the, even with treating them, you know, when we were initially trying to treat them as a unit, it was a little bit hard. She doesn't talk a whole lot when they're in there together. He sort of dominates the conversation as well. And so that's part of the potential concern as well.
And also, I would add even though naltrexone is a good option for the opioid use disorder, but usually when the patient is in more stable situation, that would come handy. In the beginning of the medication-assisted treatment, usually would not work as good as the buprenorphine and methadone for the treatment of the opioid use. So yeah, the acceptance of that kind of the treatment usually happens when the patient is constantly, you know, either was treated with the buprenorphine and then come off of it, eventually wants to have some assurance and they would accept the naltrexone, or they had some alcohol and opioid together use disorder. So that would be another option for the naltrexone. But you are right. I mean, it would be more reasonable for someone who is engaged in a treatment. I think this is one of those cases. Now, I've been involved in the treatment sometimes for this couple. So, but I think that's one of those cases that mainly still, even the motivation is there, but it's waxing and waning. So it's not something that comes first, as this is very important for me. My recovery is important. I need to engage to this. So there's a back and forth on that. Now the question is it in both cases? But because they are influencing each other, I think it does affect both of them in this situation. The only thing we can also offer is to be there when they are ready. And that's what we are doing right now. And trying to make sure that we also don't miss any other symptoms. The good thing about these two cases that I've been engaged once or twice, because they are in a low dose of the substance that they are using right now, the medication that they are using in a low dose, I'm not that much concerned about the diversion of the medication, because they're not pushing to get more and more and more. And they are managing their situation right now with the dose that we are giving them. So as long as they are coming, I would say that we need to be there for them. Is there any other comment or concern on these cases, such as this, or similarity for the cases that you guys had before?
I had that thought too. Cameron was like, clearly they left and then still felt comfortable returning after that gap. Like clearly there's trust in a relationship there. So it sounds like the work that you're doing, that hopefully at some point they'll be a bit more motivated and they'll know you're there for them, and maybe things will get better. But it seems like, yeah, there's just a lot of chaos right now and there's not a lot of wiggle room to help.
Yeah, and I would rather for them to get the medication from us than getting it from the street on this situation. So we had a concern about the harm reduction also in this situation. So to make sure that at least we are there if they need us. Well, it's 1:15 p.m. or 1:14. Is there anybody added to the list that we didn't ask them to introduce themselves? So I don't know, I didn't keep the record of that one. So if anybody is joined us during the conversation we had and they didn't introduce themselves, please go ahead and introduce yourself. Goes once, goes twice. So we're all done. Thank you so much, and we'll see you guys in 2 weeks.
Hit the leave button. Nope.
I guess we're not gonna have after session.
I was gonna say, we lost Cameron.
Yeah, Cameron just kind of left us.
Okay. I guess we'll email if we need anything.
Okay.
It seemed like it went good.
Yeah, it did. There's a pretty good number. There's 21 at one point, so.
And some new people.
Mhm.
That's good. Yeah.
Of course, very good topic as always, and some good feedback, so.
Yeah, I always really like that presentation.
Yeah, we're actually going to include that in our enduring materials, the QCOM opioid safe prescribing, the one that we're doing for the enduring material. So we're going to cut that piece out and put it in with Dr. Baumrecker's prescribing information.
Oh, cool.
And that way we'll have that as our primary enduring materials now for opioid safe prescribing.
Very cool.
So.
Yeah, no, I like that one a lot.
So is the other echo an ETSU echo that she's went off to?
It's when that I'm not sure who does it. I know it's through the state somehow. Like Brian used to help with the recordings and stuff of it, but they didn't need his assistance, I don't think. Because she kept on telling them that if they needed him, you know, to.
That is totally my fault. I am
Oh,
so sorry. I made him close out of it because I had no idea there was a meeting afterwards. I didn't realize this. I'm sorry. First time. Totally
Well, you're there.
uninvolved. Okay, so we're gonna do this together.
Okay.
Because we can't get it. Bye.
Well, I think that having it as a group here is good in one way, but it also takes away the individual, you know, kind of control of the things, because everybody wants to know to intervene, and you are going to be operator of the microphone. So next time I want my own computer and getting out and finding my own, you know, dungeon to participate. That was a little bit odd.
I know it's hard for you all there in the office, especially since there's so many people there.
Yeah,
Yes.
and it's hard to see that we're actually talking because of everything. Yeah. That's just.
So
Well, I think that question Belle had about like, should you be in the room to do the presentation? It's actually no, like don't be there.
Right. When he said that, I was like, that would be perfectly fine because it's hard because of there's so many.
Yeah. So like if you're presenting, go to your office elsewhere. Yeah.
Yeah, I think that's a good rule of thumb to have, and that we can just make sure I think our next speaker is you all, Meredith, you and
Mina,
Veronica, and
Mina, yeah, we'll have to figure that out because 3 people can't talk. That's gonna take too much time.
yeah, especially in 20 minutes.
So I'm not sure what that's gonna look like. But yes. We have emailed that meeting, but we haven't met yet.
Yeah, and Mina's out this week, so she probably won't get back to you until Monday anyway.
Okay. Thanks.
yeah, I think that the one thing that I would like to see is if someone is presenting the case, they need to put it on a paper, and we can, you know, see what information required to be discussed in the beginning, get-go. So we give a.
Yes, and we did fix. Brian had fixed it before he passed. He had fixed it to have the form on the page, so we do have access to that now. So if there is a fellow or something like that, they can, nothing else, just use the form and share from that form itself.
Yeah.
Yeah.
Well, I mean, that could be done if that person that is using the computer and presenting already signed up on this Zoom.
Right.
So they can share their screen. But this time we didn't have that opportunity. So because we were using the same room and someone else was signed in. So what I can
But like Melissa, you'd be able to pull it up, right?
Yeah, we can
Yeah.
pull it up if we have
Yeah,
Rebecca or I. Either one.
If it gets sent in, he just emailed it to me afterwards so that we have it for our records, but it wasn't in there to be able to be pulled during the actual.
Okay. Yeah, so maybe we just need to reiterate that to, especially, anyone doing that, which it's our first time and it seemed to go well. So
yes.
we had a pretty good turnout. It looked like there was up to 21, Dr. Heil. So that was pretty good for the first one.
Yeah, and we had some new people.
Yes.
That they engaged to this, from pediatrician, I heard, and gynecology and something like that.
Yeah. And I'll get those emails to you, Rebecca, so that way you can start adding them to that list as well.
Okay.
I don't know if Joyce messaged you, but that K-Ball 8 person.
Yes.
Yeah.
She messaged you about that. Like they appeared and then
yeah, she said that to me, and the only recommendation I have is just for Rebecca and I to go through the emails and see if
Part
we
of
have like a
somebody.
Christy Ball or
somebody. I'm sure it's at ETS. You don't need to. Yeah, who it is.
Yeah.
Yeah, and I made the roster as soon as everybody came on, so I have everybody who even came in and off the entire time. So I'll just mark them through to make sure we've got them or who they are. Or we'll just make an announcement, making sure that people, update their name so it's their full name, so we can make sure they get a credit for it.
Right.
CME must have a huge contact list. Does our information go out to all those contact points across the region and the state?
We sent one out across all of ETSU. We have one that we can look at to go through constant contact that's kind of been associated with programs in the past. And we can send that through constant contact just through that would be anybody in the state that's ever done anything with CME previously. So that would be another probably a good 300 participants. And then yesterday we sent it out to the College of Nursing and the College of Medicine as well.
I thought if they just got a reminder every now and then, it wouldn't have to be as frequent as what we get, but.
Yeah, and that way we'll just add them each time to the reminders as they kind of join us. And how frequently would you do that? Like quarterly or monthly or?
Yeah, no, maybe quarterly. That way they just don't fall off the face of the earth. And, everybody needs a reminder. Everybody's got too many things going on.
Right.
So
especially right now with school starting back and everything, it's been crazy.
So.
Yeah, we'll make a note for that.
It seems like the nurse practitioner students, like there's new ones. So they must that. Remember we were questioning if that was going to be a requirement still, but I'm thinking maybe it is. So that's cool.
Yeah, we made sure that that may be a good thing each time to send through the College of Nursing, since it is, only twice a month.
Yeah.
Because I know Dr. McCook, I'm not sure, has she ever joined us before with this program? I don't know if Dr. McCook had ever joined us before with this program. I know she's worked with some other programs, but I'm not sure about this one.
I feel like I recognized her and I can't think of how I would know her otherwise, but I don't know.
So I know she does a lot of the SANE nursing stuff. We have a ton of SANE nursing programs and that kind of thing through CME. But yeah, every few people we can get through that and their connections. Yeah, definitely. And pharmacy credit is one thing that I've had a hard time getting so far. We had 4 pharmacists there today. So I might send that back to them. I applied for pharmacy credit in late July. So it's been over a month now. But I will just remind them that there was 4 pharmacists there today. I think that would be beneficial as well. And we can start marketing that to the College of Pharmacy as well.
I feel like we have a fair amount of our content is like pharmacy-ish.
Yeah, a lot of it. Yeah.
All right, one down.
19 left to go.
Keep on learning from the day, and we did good today. So
Yeah, it's better.
That's a good level to start at.
Yep. Thank you for bearing with us on our first echo. I know you guys have been doing this for a very long time, but it'll get better.
You're doing good. Once you start looking at it tomorrow, if you need anything, Rebecca, just holler at me and I'll make sure you get there.
Thank you.
No problem.
This time I don't go under the peer pressure and leave.
Totally me. Totally my fault.
It
All
was
right.
everyone
Yep.
trying to
Just
tell me
close it
how to
out.
get out
Close
of
it out.
the Zoom.
So I know, most of them where'd they go? What happened?
All of a sudden, I thought that 7 people here, they think that after a year and a half, I don't know how to get out of the Zoom.
I mean, who knows? Like,
You
no
never.
judgment.
I know, it's age related too, so,
Give you a little mental static exam, oriented it in place.
yeah, mini mental.
Hey, have you ever?
You guys take care. Thank you so much.
Ask real quick, have you ever worked with Kathy Dyer? She's the executive director of the Tennessee Academy of Family Practice.
Look, I've heard that name before, but
I mean, if she would promote it, that's got to be a big
Yeah.
group. I know her fairly well from going to the Rural Health Association of Tennessee, but I just noticed Daniel Lewis is their current president. He's a ETSU grad. He's a family guy in Greenville. He actually caught COVID last year. And Beth Fox, James Holt are on their executive, Jim Holt are on their executive board. And, they're both ETSU family doctors. So, I mean, they probably have a membership of hundreds upon hundreds family doctors, so if she would help us out.
is there any way you can send me her information, Rick?
I can, I'll do it.
And I'll follow up with her.
All right.
Yeah, that's a
Yeah,
good idea.
that's probably how I know it, because I used to be somewhat more involved in the Rural Health Association prior to our
Right.
department changes here. So but I'll reach out to them for certain, because that's a good idea.
Okay.
Thank you, Rick.
Thank you for that.
Bye. See you soon.
Bye.